Dr. Kedland. Thanks for watching. Let's talk about impetigo. Comes from the Latin impetere, meaning to assail. It's an acute, highly contagious infection of the superficial layers of the epidermis. It's the most common bacterial infection in children, and it's the third most common skin infection in children, just behind eczema and warts. Typically, it's due to strep pyogenes. It's a group A beta hemolytic strep, also called strep pyoderma, or it could be caused by Staph aureus. It's also a gram-positive bacteria. Sometimes it's sensitive to methicillin. Sometimes it's resistant. When it's resistant to methicillin, we call it MRSA, that most people have heard of. Only rarely is the disease due to some other kind of bacteria. Now, what's more prevalent, the strep or the staph? It all depends what we're talking about. So in the 1930s, it was more common due to strep. Then in the 40s and 50s, it was more common from staph. Then in the 60s up to about 2000, more common in strep. Now we're back to staph again. But remember, it really doesn't make too much difference whether it is strep or staph as far as most people are concerned. And how we make the diagnosis is mostly visual. We don't even culture it, so we're not really sure which cases are strep and which are staph. They all look alike. It's said that Staph aureus affects about 80% of the cases of impetigo, and the group A beta hemolytic strep only about 10%, with both maybe anywhere between 20 and 45%. But the idea now is that it starts off as strep, and then the staph overgrows it and gets rid or eliminates the strep. Now the strep is mostly group A, but sometimes it's group B. More common group B in impetigo in newborns, rarely group C or group G. Now we tend to think that all strep is alike, but it's not. Not only do we have group A and group B and other groups, but we also have subtypes. So we have type, for the impetigo, type 49 and 52 and 53 and 55 and 6 and 7 and 59 and 61, and those are all very important because they have different kind of meanings. And then for staph, well, we have different kind of staph. One we're interested in produces a bacteria toxin that's toxic to the strep. That's why it eliminates the strep. Now we can classify impetigo as the more common non-bullous type, or impetigo contagiosum it's called. That's about 70% of the cases. It's more contagious than the bullous form. And then we have the bullous form. And the bullous form looks completely different clinically. Looks like a big blister or multiple big blisters on the skin, more like you would get from a burn, but you don't have the history of a burn and it's in the wrong location. We can also classify impetigo as either primary or secondary. Primary is when it happens on normal skin. Skin looks otherwise normal, healthy, unbroken. Maybe there's a little insect bite or something of that nature that pierces the sanctity of the epidermis. But usually the skin seems otherwise healthy. It's most common in children, but any age can be affected. Secondary impetigo occurs when there's a visible breach on the skin's surface protective layer, maybe a rash or a dermatitis or eczema or a scratch. Maybe it's a cold sore or scabies or some sort of pre-existing wound. Break in the surface of the skin can come also from fungus infections and lice and insect bites and surgery and trauma and scratches and burns and radiation therapy. On primary impetigo, it could either be strep or staph, but secondary impetigo tends to be staph much more commonly. And secondary impetigo is much more common condition than the primary, so usually occurs on some visibly damaged skin. Now, sometimes there's a history of exposure to an individual who's a carrier of staph or strep, or somebody has maybe a skin condition like eczema that predisposes to being a carrier. Maybe there's a cluster in the family. This is extraordinarily common. It's estimated in the United States that there are going to be more than 11 million skin and soft tissue infections from staph every year. So at any given time, about 2.5% of the population has some kind of infection on the surface of the skin. In some populations, like the Australian Aborigines, at any given time, the incidence of strep or staph infections on the skin is about 40%, 40%. It can occur at any age, but it seems to be most common in children between the ages of 1 and 8 years. but it's especially common between 2 and 5 years of age. So if we look at young children less than 4 years of age, it occurs about 2.5 to 3% of those children every single year. If we look at children who are somewhat older, say 5 to 15 years of age, 1.5 to 2% going to develop the condition at any given time. Now in the world, there are about 1.6 billion children. And the number of episodes of impetigo in the world, just in children who are less than 15 years of age, in any given year, is going to be between 110 million and 160 million, and that doesn't include adults. Well, the condition can affect anyone. All races are included, but it tends to be a little bit more common in the summertime and in the fall in temperate areas, but it's without any kind of seasonality if you go to the tropics where it's warm and humid throughout the year. There's increased incidence also in the tropics because they have more biting insects. Overall, it appears that the incidence is about the same in males as it is in females, but if we look at adults, more common in men than in women. Now, somewhere around 95% of people with impetigo only get one infection in any given year. About 25% of the time it's due to some underlying eczema. About 7% of the time it's going to be recurrent, but that depends on the circumstances. Higher incidence, of course, in people who have eczema or people who have cold sores. Now, the intact surface of the skin tends to resist colonization with either staph or strep. But there's introduction from the environment that allows the skin to be a transient, to be transiently colonized by the strep or by the staph. Now, if we went into the laboratory and got some staph or got some strep and put it on otherwise normal, healthy skin, wouldn't cause any kind of infection, wouldn't cause any kind of problem, wouldn't cause any extra burden unless the skin had a perforation. Now, a person can be a carrier. You can have some colonization that occurs typically in the nose in up to about 30% of the people at some period of time, usually not for prolonged intervals, but some people can have extremely long intervals and they can be carriers. And then the bacteria can spread to the surface of the skin, typically around the nose or around the mouth, and then you can develop impetigo about a week later. Up to 10% of the people have at some point in time some colonization of the staph, either in the perineum or in the underarm area or on the hands. That's one of the reasons you don't want to continuously wash your hands. And if you do wash your hands, you want to wash the palm side rather than the other side. Because if you irritate the skin too much, then you set up a condition where the staph tends to develop on the surface of the skin. So if we look at people who have eczema, that childhood eczema or atopic dermatitis it's called, we can have colonization in more than half of those individuals. And it seems that circumstances in the environment can make the skin extra prone to colonization with either the group A beta hemolytic strep or the staph, high temperature, high humidity, pre-existing skin disease, young age, or recent treatment with antibiotics. Another reason why we don't like to use antibiotics when they're not appropriate. And crowding seems to increase the likelihood. So in a home environment, or in schools, or athletic teams, or in nurseries, or in daycare centers, in the military. And you have an extra risk depending on your status. So if you're malnourished, if you're an intravenous drug user, if you're on immunosuppressants or taking steroids, or using some of those medicines that are advertised on the television for psoriasis and for rheumatoid arthritis, or if you have immunodeficiency, or if you're being treated for cancer, you're taking medicine to prevent rejection of a transplant, or you just have poor hygiene, poor personal hygiene, maybe limited shower facilities or limited availability of washing machines. That predisposes to having more bacteria on the surface of the skin, and then all you need is the nick. Well, there are the two types that we talked about, the non-bullous, which is the most common, and then we have the bullous. Well, the non-bullous demonstrates itself as multiple coalescing lesions that tend to be localized to one or more areas of the skin, typically around the face, around the nose, around the mouth, but it can be on the extremities or anywhere for that matter. It begins as small, clear blisters, tiny blisters, sort of same sort of look you would get with early cold sore. And then it turns into yellowish pustules that eventually, several days later, rupture. Then you have a honey-colored crust with a scab and a moist reddish base. And eventually, the scab's going to slough off. Then you're going to have a little red patch that'll last for several days to several weeks. You get multiple lesions at the same time. Oftentimes, they coalesce into a larger lesion. The skin around the impetigo looks otherwise normal unless you happen to have eczema there. It's a non-scarring condition, but it can leave the skin either a little bit darker or a little bit lighter for weeks to months afterward. And because it's a bacterial infection, you can auto-inoculate yourself. So even though it starts off around your nose, if you keep touching it and scratching it, and sometimes it's an itchy disease, if you scratch it, you get it on the surface of your skin, some of those bacteria, and then you scratch your leg, and you have a little nick on your leg, then the bacteria all of a sudden are in your leg, or you touch someone else and you can spread it to someone else. Actually, the impetigo is one of only 2 diseases with the word contagiosum in the official name. It's considered a self-limited disease, tends to occur typically without redness or swelling. It's not on the palms, not on the soles. Tends to resolve even if you don't treat it. Tends to resolve in about 2 to 3 weeks. The redness, as I say, can stay for several days, several weeks longer. People who are infected with impetigo, people who have the condition, tend not to have any systemic symptoms. They don't have fever, they don't have malaise, they don't have weakness. There's no pharyngitis or sore throat, even though it frequently is due to strep, and the strep, like I say, can be around the nose or around the mouth, but it's a different type of strep that causes strep throat. Different kind. Remember those M types, the 49, 51, 53, 55, 7, and all that? That determines where the strep is going to nest on the body. Now, sometimes people who have impetigo can have enlargement of the lymph nodes, that's locally. And sometimes, if the impetigo goes deeper into the skin, then you get ecthyma or erysipelas or cellulitis. And we contrast that with bullous impetigo. It's much less common than the non-bullous impetigo. 90% of the cases occur in individuals who are less than 2 years of age. And as a matter of fact, if you have premature rupture of the membranes, then by the time the child's born, might already have the lesions of bullous impetigo. Bullous impetigo is about 30%, the non-bullous is about 70%. Lesions can occur anywhere on the face, on the extremity, in intertriginous areas like the axilla or the perineum around the personal parts. And they can occur at sites of friction, like from the diapers or tight clothing. The number of lesions tends to be fewer than in the non-bullous type. And by the time people present to the doctor, typically the blisters have already disappeared. They ruptured. So the blisters themselves tend to be very thin-roofed. The fluid in them is not tense. It's not like one of those burns that you see where you have the tenting of the skin. But these are just clear, flaccid bulli. Eventually they might turn yellowish. Ultimately, they can get cloudy and then dark color, and then they rupture. And once they rupture, there's just a little rim of scale around the periphery of where the bulli was. Sort of looks like you had a burn. The blisters themselves tend to be less than about 1 inch in diameter. They don't coalesce like the lesions do in impetigo. Autoinoculation does, however, occur like in the non-bullous type. Almost always, the bullous type is due to Staph aureus, because it makes a toxin that causes an erythroderma and a sloughing of the skin. It can occur on intact skin without any surrounding redness of the uninvolved skin. And on occasion, it can actually involve the inside of the cheek. That's unlike the non-bullous type. And if it's extensive in children, in infants, then sometimes they can develop some systemic symptoms, some fever, malaise, some weakness, and diarrhea. Rarely there's lymph node enlargement. It's bullous impetigo because the staph produce an exfoliative toxin. We call it an exotoxin, and that exotoxin affects the desmogliin. That's one of those substances that causes the skin cells to contact each other and to stay intact. Well, the exotoxin ruptures the desmoglein, and then you can get the blister. Well, the blister stays local. It's not a systemic problem. Now, if we talk about impetigo in general, it appears that about 20% or more of the cases of impetigo are due to the methicillin-resistant Staph aureus. But that's not really an issue. It's not the same kind of Staph aureus that affects the heart or affects the lungs or affects the liver or affects the kidneys. So we don't have the systemic spread. If we talk about non-bullous impetigo, well, we can have a complication. The complication, fortunately, is relatively uncommon now in the United States. It used to be much more common. And it's called acute post-streptococcal glomerulonephritis. And that affects the kidney. It tends to affect children between the ages of 2 and 4. It comes on about 10 days after the impetigo first appears. But it could be delayed by up to about a month. The onset tends to be some swelling in the feet, some swelling in the face, some high blood pressure. The urine tends to be dark because it has blood in it. When it's measured, we also find that there's protein in the urine. Acute post-streptococcal glomerulonephritis associated with impetigo can't tell the difference between the normal impetigo and impetigo that's going to give you this condition. It's just that it's a different strain. It's a nephritogenic type of a strain of the strep, not the staph. And now that staph is a much more common type, we have even less of a problem with this in the United States. It's mostly in resource-poor areas of the world where this is a problem. And it's interesting that treatment of the impetigo, even treatment early on, doesn't seem to change the course of the post-streptococcal glomerulonephritis because that condition in the kidney is an immunologic condition. It's not an infection. It's the body was stimulated to make the antibodies against the organism that was on the skin, and then those antibodies circulating through the system are seemingly what causes the problem. Now, we call it beta hemolytic strep because if we grow it on blood, it completely ruptures the red blood cell membranes, and then we get a clear ring. That's beta hemolysis, as opposed to alpha hemolysis. When you get your pneumonia in your lung, that's a strep pneumonia. That only partially ruptures the red blood cell membrane, and then we get some greenish discoloration. Now, the group A beta hemolytic strep can cause other conditions as well as impetigo. So relatives can cause the sore throat, the pharyngitis, the scarlet fever, the toxic shock. Can cause some of the conditions like rheumatic fever, and PANDAS. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder with strep infection. So we have the strep infection, and sometime afterward, the child all of a sudden starts demonstrating obsessive compulsive behavior. Well, we can do a lot of fancy tests, and we can look at what kind of staph or what kind of strep, but for the overwhelming majority of people, it's not very important. But what is important is there seems to be some sort of a correlation with scabies. Now, scabies is a mite infection. So it punctures the surface of the skin, but just a little tiny bit. But that's enough for the strep or the staph to get in. But additionally, you scratch at the skin because scabies is very itchy. But additionally, it seems that the mite produces some compounds that can inactivate a component of the immune system, the innate immune system, that we call complement. And complement's necessary to target the strep and the staph so that the body can kill it. So without the complement, then we have a greater incidence of the impetigo. Well, the MRSA, that was rising at pretty dramatic rates up until relatively recently. It seems to be stabilized or actually going down a little bit. If you looked at a skin rash, well, it could be impetigo, but it also could be fungal infection, more commonly a cold sore or shingles or folliculitis or just insect bites or contact dermatitis, or the lice or the scabies or cellulitis or erysipelas, or even a drug eruption, or even some immune conditions on the skin, something like erythema multiforme. The diagnosis is visual. Just look at it and seems to be relatively common, so most people know what impetigo looks like. We don't tend to culture it because, after all, we've already discussed that the strep and the staph frequently colonize the surface of the skin, so we won't know if we get a culture that shows some strep or some staph if that's really the culprit or if it just happens to be sitting there. Now, we might want to do a culture in people if there's an epidemic or if a person has the post-streptococcal glomerulonephritis, see what the strain is. And sometimes it's appropriate to check to see in those individuals who get recurrent infections if they happen to be carriers. So maybe they have it in their nose or the axilla, or maybe they're carrying it in the underarm area. Some of the blood tests to show the anti-streptolysin O or the anti-hyaluronidase or the anti-deoxyribonuclease B, those tests are basically not necessary to be done. But sometimes if you get recurrences, maybe we want to check, see if you have some immune deficit. And certainly for people who develop the hypertension and the swelling afterward, we want to do some tests of the urine to see if the situation is related to glomerulonephritis. So you have the impetigo. What do? Well, don't touch it. Keep your fingernails short. Avoid close contact with other individuals. Cover the lesion if appropriate, but you don't put a Band-Aid on it because a Band-Aid is going to macerate the skin and actually predispose to spread. Cleanse the area with soap and water. That's always a good idea. The traditional concept has been you should stay home for 24 hours after you begin appropriate treatment, but now oftentimes we don't even treat the condition. That advice, by the way, is more appropriate for the strep than with the staph. And remember, it can be spread by fomites, so it can be spread by clothing and toys. Even without any kind of treatment, tends to go away in a couple weeks, especially with good hygiene. Or sometimes all you have to do is improve the underlying condition. So if the condition was caused by eczema, maybe treat the eczema. Maybe that's all you have to do. Treat the scabies if that was the problem. And remember, it can be auto-inoculated from one area of the body to another or from person to person. So maybe if we treat it, we can reduce the likelihood of some of those kind of problems. Treatment is cleanliness and a topical disinfectant. Now, topical disinfectants are on the outs these days. People have a tendency to want to use the fancier treatments, but there really isn't anything better than soap and water. It could be antibacterial soap or just regular soap. Could be saline soaks or dilute vinegar or chlorhexidine or the iodine. Any of those seem to improve the condition quite dramatically. Now, marginally, they're not really as good as the topical or the oral antibiotics, but the topical and the oral antibiotics are just a smidgen better than keeping the area clean. If we go with a topical antibiotic, and that's probably a good idea rather than the systemic antibiotic because, well, the systemic antibiotics obviously have more potential for complications. So if we use the topical antibiotic, we remove the crust, remove the debris, soak it off, then use a topical antibiotic, and only rarely, about 10-15% of the cases, do we have to resort to an oral antibiotic, the medicines like the bacitracin or the polysporin or the neomycin. They're okay. They can be quite helpful, especially because the condition goes away by itself without any kind of treatment in a couple weeks. But mupirocin or Bactroban seems to be the preferred topical agent right now in the United States. Put it on a couple times a day, 2-3 times a day for about a week. Use the ointment seems to be better than the cream. Now the brand name of the Bactroban is only available as Bactroban nasal to be put inside the nose for those people who are carriers, but it's horribly expensive. The generic is just as good. Actually, the mupirocin is as good as oral Keflex, and both of them are better than the bacitracin or the polysporin, all of those kind of medicines. There's a new one as of 2007 that's called Altobax. Altobax has a wider spectrum than mupirocin or Bactroban, works on even resistant organisms. It's derived from a fungus. But actually, it's not necessary. In the overwhelming majority of cases, doesn't really add anything to the mupirocin that's a lot cheaper. In Europe, about 80% of the cases are treated with a topical antibiotic not available in the United States. It's 2% fusidic acid. It's applied topically. Seems that they're increasing resistance to it, but it still works very well. There's a new topical antibiotic that was recently introduced to the United States called Xepi. It's 1% ozenoxacin. This is a relative of Cipro and a relative of Levaquin, but the Canadian Agency for Drug Technology evaluated it and said it really doesn't add anything new. It doesn't do anything for us, and it's expensive to boot. Then we have topical antibiotics like topical minocycline or clindamycin or gentamicin. Those typically aren't used. Mupirocin, you can buy it with a coupon from GoodRx for $12 to $19 a tube, but the Altabex, it's going to cost you, even with the discount coupon, $300 plus. The Xepi, again, $300 plus. The fusidic acid not available in the United States. We could choose a systemic antibiotic. Well, they're for more extensive disease. They're for athletic teams who have clusters, or maybe it's in the family and multiple members seem to be affected, or for the bullous lesions, or maybe for non-bullous lesions that have been treated with a topical antibiotic and don't seem to be improving after 3, 4, or 5 days. So systemic antibiotics, we want coverage for gram-positive organisms, because both strep and staph are what we call gram-positive. Now, penicillin V used to be appropriate, but now some of the strep is resistant and the staph is increasingly resistant, so that's not a good choice. Generally, we want to avoid Cipro and we want to avoid Levaquin, first of all because they're in the fluoroquinolone family, and they have negative effects on the tendons and on the joints and the central nervous system, and they cause peripheral neuropathy, and they're not very good staph drugs anyway. So if we're going to go with the systemic antibiotic, we want to go with an oral antibiotic. There's no reason to get a shot. And 3 days is probably as good as 7 to 10 days. Cephalosporin, the old-fashioned Keflex is pretty good. Dicloxacillin is good. Amoxicillin is good. Don't really need augmentin for the overwhelming majority of people, and only in special circumstances do we need drugs like clindamycin or Bactrim or doxycycline or minocycline. And the erythromycin products like erythromycin itself or clarithromycin, they don't seem to be terribly appropriate. Now, the National Institute for Health and Care Excellence, or what's referred to simply as NICE, which is a British organization, they came out with some guidelines in 2019, and basically, and they set the policy for England, what's appropriate, what's not appropriate. And they say a topical hydrogen peroxide cream probably is about as good as anything. And if you just rub that on a couple times a day, then chances are you won't have to go to a topical antibiotic. But if you do go to a topical antibiotic, which would be the first choice, they like fusidic acid, and second choice would be mupirocin. And if you need an oral antibiotic, at least over in England, the flucloxacillin that's not available in the United States, but it's close to our dicloxacillin, that would be the appropriate therapy. Now, for some, all we need is a little topical steroid, treat the eczema, or maybe combine that with the topical antibiotic, and that might be appropriate. And if you have a fungus, we'll treat it with an antifungal topically. So the topical antibiotics and the oral antibiotics seem to be equally effective. The difference is in the cost and the side effects. And remember, if you take the oral antibiotic, you're going to mess up all of the bugs in your gut. And then you're going to end up with a sore stomach and diarrhea or constipation, or you're going to have some other situation, and you're not going to get back to normal intestinal flora, normal intestinal bacterial content, for weeks to months, or maybe, and sometimes, forever. Well, in the Netherlands, about a quarter of the people are not treated with any antibiotic at all. They're just treated with soap and water. About 60% of the people are treated with topical antibiotics, and about 10 to 15% are treated with systemic antibiotics. So systemic antibiotics for treatment of impetigo on the way out. And remember, spontaneous healing is going to occur in the overwhelming majority of people by up to maybe 50% within the first week, and then the rest in the second and the third week. So the bottom line is impetigo is quite common. It can affect anybody, but it's more prevalent in young children. It's usually caused by either strep or staph. It affects the superficial layer of the skin, tends to go away within 2 to 3 weeks. Most of the time, all you need is topical soap and water. You could use some topical antibiotics, and only rarely should you resort to oral antibiotics, because after all, oral antibiotics have other kinds of complications, and we're always worried about the potential for resistant organisms. And finally, well, we have to think that if an individual does have widespread disease or has some other underlying condition, then we might have to resort to oral antibiotics. And remember, to minimize the risk of spread, pay attention to hygiene and keep your hands where they belong. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you get the new episodes as we post them. And as always, I appreciate your interest. I'm Dr. Ken Landau.